It's a great pleasure that we welcome Safa Rahman, a pelvic health physiotherapist with Vesia, the Alberta Bladder Center in Southern Alberta Institute of Urology. So up in the center, I believe, with Dr. Baverstock and the group up there. Many of you would have already read Safa's impressive biography, which was in the April issue of the Digital Examiner. But what you may not have read there, and I know you didn't because it wasn't in there, and you may not be aware that last November, Safa participated in the Qualified Exercise Professional Oncology Education Week. Now, I had to write that down because it is a mouthful. It was presented by the University of Calgary Health and Wellness Lab and the Faculty of Kinesiology with our great friend, Dr. Nicole Coulis-Reed. So Safa's presentation on pelvic floor considerations in exercise oncology, the presentation's available on YouTube, but tonight, we're fortunate enough to have Safa here live with us, direct through Zoom. And let's give Safa a warm prostate welcome. And I look forward to hearing more on what she's got to share with us this evening.
So thank you so much for including me. I'm always very excited to talk about pain. It can be a very complex and very layered subject, especially when it's coupled with cancer. So I called this presentation Demystifying Chronic Pelvic Pain Syndrome. This title is taking the place of what used to be called chronic prostatitis. And so we'll go through kind of what that means. And hopefully this won't be too boring because I find all of this quite fascinating. So as with every presentation, I always like to do a short little land acknowledgement as we are all guests on this land. So we are currently on the traditional territories of the people of Treaty 7 region in southern Alberta, the Blackfoot First Nation tribes of Siksika, the Pikuni, and the Kainai, the Stoney Nakoda First Nations tribes of Chiniki, Bearspaw, and Wesley, and the Tsuut'ina First Nation. Calgary or Mohkinstsis is also home to the Northwest Métis and the Métis Nation of Alberta Region 3. So pain can always be quite concerning. And the first thing before we do anything is always to check with your healthcare team or your general practitioner. So either the team involved with your prostate cancer care or your family physician. So the first things that happen are always to check for any medical concerns. So infection, bladder, kidney, any sexually transmitted infections, and of course, all of the normal prostate tests that everyone's familiar with. So PSA, digital rectal exam if necessary. And if there is some degree of inflammation, that's when antibiotics come in or any appropriate medications at that time. Before I see people, when they have pain that could look like prostatitis, I always send them to their physician first. Depending on the location of pain, especially if location is around bladder or around prostate, so just above your pubic bone or slightly behind, I let the physician decide if there are any further bladder investigations that need to happen, whether it's a cystoscopy or urine tests. So if anyone has ever not been to physio, we always start with an orthopedic framework. So all of us with a physiotherapy degree, we always will look at how your body moves through space, your bones, your joints, and how they interact with each other. So when you first come to physio, we will ask you a whole bunch of questions, not only related to your skeletal system, so bones, joints, muscles, nerves, but also things that could relate to or contribute to discomfort in your belly or in your pelvis. So we'll ask about any injuries that you've had, any surgeries, any broken bones, especially if you've had any tailbone injuries. So what I usually say is, have you ever fallen on your tailbone and has it hurt for more than 5 days? Usually with any sort of tailbone injury, there isn't often any internal treatment. So that's important to me. So even if an injury has happened and there hasn't been any treatment or x-rays, that can actually affect things down the road. And so there are certain practitioners that will do internal treatment, and even years and years and later, it can actually make a difference. So then we look at location of pain to try to figure out where it's coming from and what could be contributing to it. So suprapubic is around where your bladder and your prostate are, so just above your pubic bone. Testicular pain, what a lot of us call groin pain, which can still mean a few different things. It could mean inner thigh, it could mean where your thigh meets your pelvis, it could be lower belly, and of course, low back. Low back injuries are very important, or any history of low back injuries, because the nerves that go into your pelvis actually originate higher up, as high as T12. So T12 is the bottom of your rib cage, and so the nerves, even that high up, can actually affect things going into your pelvis. So I'll always check that if necessary. And then we ask about bladder. So typical questions that you will get are, is it easy to start your flow? What is the strength of your stream? Is it an even stream, or is it start and stop? And do you feel like you're emptying at the end of your voiding? The other big question is questions about bowels. So if you have bowel cramping, any tendency towards constipation or diarrhea, and if your bowels are predictable. So do I know that when my body is the happiest, do I have a bowel movement at the same time every day? And is it once a day, every 2 days? Basically what your normal function is, and if there is any pain involved. Another thing that really helps me is I will always ask about quality, shape, and size of stool. And it sounds so strange, especially when we're talking about pain, but that gives me an indication of if there is any bowel activity that could be contributing to pain, but also if there is any muscle tightness. So with muscle tightness at your pelvic floor, what sometimes happens is your stool can come out really skinny, or it can come out curved like commas. So it's an interesting thing to every once in a while look down and see if your stool is soft, formed, no pain with the movement, and pretty much straight. So we actually have a stool chart. So there's 7 different shapes of stool. And so we want to aim for what is the type 4, which is formed, pain-free, and pretty together. So if it's too loose, we go this way. And if it's too hard, we go this way. And on the chart, when stool has less and less fluid out of it, it actually ends up looking like little stones or pellets. And if you have a bowel movement where your stool has 2 different types of stool in it, that's also really important for me to know too, because that tells me if some of that stool in that same bowel movement has actually been in there longer. And so that gives me an indication of, are you fully emptying every time? And are your muscles actually keeping you from doing that? So lots of weird questions from me when you come, just so we can try to demystify it and break it apart a little bit. So the physical part of the assessment, typically I will always start with a generalized assessment. So I have people standing, I see how your posture is, I see how your body moves through space. We do a couple of quick little balance tests with my hand on your pelvis, and we'll see specifically how your core stability is and how your joints are functioning when we change your base of support. All of these things are important for walking, for function, for lifting, all the things that you do during the day. Then I put people on their back and I put my hands on your belly. When my hands are on your belly, I'm pretty much palpating or putting my hands and pressing from your lower ribs down to your pubic bone. And the importance to that is that everything within that area can affect each other. And that is specifically what we call your core. In your core, we kind of think of like a Coke can or a pop can. All of those walls actually have a relationship with each other. So when I look at the structural framework of that core or that canister, not only do we want to make sure that the muscles are intact, but all of the things that the muscles are attached to. So if you have a lot of ribcage stiffness, when I take a breath in, I may not actually get a nice full breath, which seems like it may not be involved, but because your diaphragm is the top of the container, if I don't get to do this and allow length to happen within that container, it can actually feel like it squishes a lot of that pressure downwards. So I talk about that a little bit in the Road to Recovery program, that if you don't have a nice full breath, we're actually potentially compromising your pelvic floor healing after surgery. So all of these things, even though they have subtle implications at times, when we are talking about pain, all of these things become really important. So breath pattern, when you are breathing, do you breathe through your belly? Do you breathe through the apical part or your chest and your shoulders? And how is that affecting things further down? So just inside of the skeletal framework, we look at the muscles. So the top part of that canister is your diaphragm, which is your big breathing muscle, which is why it's big and fat. It's like an upside down bowl. Every time you breathe in, it goes like that. When you breathe out, it comes up like that. So when you're breathing out, there's a lengthening and almost like a suction that happens in that container. Your belly muscles and your back muscles go all the way around and form the walls of that container. And the bottom is your pelvic floor. So this is the basis of how a lot of us as physios think about function and how everything kind of fits together. So when we talk about strengthening your back by strengthening your belly muscles to make your back stronger, all of that, it has to do with this whole system, which we really think of like a pressure system. So when I think about this container, I have to be able to strain if I need to and safely have my muscles adapt to that increased pressure and then have that container change again. So this is one of my favorite pictures of teenagers. So if you think about the canister staying nice and tall, we don't want your pop can to become crushed. So when you are standing and moving around through the world, we don't want your rib cage to squish and fall towards your pelvic floor. And then we end up looking like the teenagers on that side. So your pelvic floor are the muscles right underneath you. So if everyone's sitting right now, you can feel as though you're kind of sitting on two bones that are right in your bum. So I'm sitting on top of these two bones. A lot of us just call those bones your sit bones. They're called your ischial tuberosities, but your pelvic floor is in between those two sit bones, your pubic bone, and your tailbone. So it's actually a diamond shape that should be right underneath you, okay? The really interesting thing about this muscle group is that there's two kinds of fibers. It's one of the only places in your body where there's a significant amount of both what we call fast twitch and slow twitch fibers. Fast twitch fibers are the ones that do this. They do a lot of dramatic contract, relax, open, close. Slow twitch fibers are the ones that are a little bit tight all the time to actually help hold things up. So just like what we call your core stability muscles, so your deep belly and back muscles, there are parts of your pelvic floor that we want them to be active a little bit all the time, just so we can hold some of your organs up, especially in the back part of your pelvic floor. Again, like all the muscles within this container, we need them to be able to be adaptable. So not just strong and weak. So not just about the strength of it, but we need them to be able to shorten and lengthen for what we need them to do. Okay, these are my beautiful photos of utter confusion. So if you look at the picture on the left, you have your rib cage, spine, and then that heart-shaped bone at the bottom, which is essentially like a ring or a bowl, and that's your pelvis. If I take that pelvis and I lie this person down on their back, okay, so the head is away, feet are towards me, then I take off skin and fat. That is the picture on the right, on the top right. So somebody is lying on their back with their head away from me, and I've taken off this skin and fat. So that's your pelvic floor, the top picture there. What you'll notice is the tailbone is on the bottom and the pubic bone is on the top. So your pubic bone is actually a joint. It's two bones that come together with the cartilage in the middle, but we call it your pubic bone because it doesn't move very much. So we just think of it as one big piece. Your sit bones are on either side, and then there's a bone attached that forms the top half of the diamond. What's interesting to note in these two pictures, and I put both of these on because the bottom picture is somebody with their head towards us and their feet away, and we've cut somebody's belly down the middle and we're looking down. So the reason I put both of these on, we don't have to memorize this or anything like that, but what I want you to notice is that they're slightly different. And your pelvic floor is essentially a number of different layers of muscle, and that's why they look different. Some of them are big and fat, some of them are really skinny. A couple of those muscles are actually exactly like a true sphincter, so a circle. And so when that muscle contracts, it actually does this, and then like that. So contract and then relax. And you can see from the shape of these muscles that they're actually doing different things. So the ones in the back, they contract kind of like this, but they're actually not attached to anything that moves. And so those big ones in the back, they just basically get soft and tight on the spot. So those are your shelves for your organs. The other ones, the ones that are like a U shape, contract like this and then relax back. So those hold a role in helping to keep bowels, like stool in your bowel, but of course, also with your bladder to maintain continence. Okay, so now we're going to get into specifics of what can potentially contribute to pain. So as we know, with your pelvic floor, we want your muscles to be able to contract and relax. Do it this way, contract and then relax. I always think about your muscles kind of behaving like a jellyfish. If I think about a jellyfish floating slow motion through water, contracting pelvic floor is like this, relaxing pelvic floor is almost like a drop and spread. So one cause of pain can actually be the limit in that movement of those muscles. So what can happen is your muscles can actually get too tight or too strong and forget to let go. And that can happen. It's typical that we think, especially after surgery, that we have to work on strengthening, which for the most part is true. Sometimes, if you start off with certain parts of your muscles tight, we actually have to work on the relaxation. And the thing with your pelvic floor is because it's so layered, it could very much be one part of your pelvic floor and not the whole thing, which is why it's really nice to get an assessment done to see what exactly is happening at your muscles. So a shortened pelvic floor can be a significant contributor to pain, especially if it's at the front. So when those muscles are short at the front, like that, so it's a diamond shape like this. So sometimes that can feel like pressure in the front. It can feel like difficulty starting your stream. The symptoms with bladder are very similar to prostatitis, or if you have a lot of pressure on from the prostate on your urethra and it feels like somebody's stepping on a garden hose, right? That it's really hard to get urine out. The same thing can happen with the muscles. So that's why we start with prostate treatment. And then if it's not that, if your prostate is still there, then we actually check the muscles, right? If we know everything's medically safe, then we see if the muscles are what's actually holding it there. So with this, it's actually more difficult to treat shortened pelvic floor than it is weakness often, because we have to get your body to actually feel what it feels like to release instead of tighten. So that's when having a practitioner becomes very useful, because there's a lot of different visualizations that we can do, and it starts to go into a lot of mindfulness and breathing and relaxation that really help us to manage pain that's from shortening. So if anyone has heard of a syndrome called hard flaccid syndrome, it's a relatively new title, but hard flaccid syndrome describes shortened pelvic floor and how it affects a lot of men. So hard flaccid syndrome essentially describes this feeling of your penis feeling a little bit rigid all the time, so not completely flaccid, almost as if you have a sense of it being there. And what that means is that after erection, what happens is that the muscles, because they're tight, don't allow the fluid to completely drain. That's what it essentially feels like is happening. It feels like there's always something a little bit in there. Again, those things are associated with pressure, local discomfort, sometimes issues with urination, and very common with people that are very, very active. And so what happens is that their pelvic floor strengthens while they're doing a lot of high impact activity. So running, jumping, HIIT programs, things like that. And then post exercise, when you're doing stretching, what happens is sometimes your pelvic floor doesn't fully let go. So that's something we see quite a lot. Again, issues with your bladder. What is typical with a shortened pelvic floor is pain is often worse after ejaculation. And the reason for that is with ejaculation, what happens is your muscles tighten up, then they do a bit of a flickering and then let go. If your muscles are in a state where they're used to being really tight, what happens is they try to do that spasm and then it's just so tight that they actually can't let go after. And so oftentimes people have a significant worsening of their discomfort for about an hour, sometimes even longer. And sometimes men have to actually stretch, do some relaxation exercises, or even take a hot shower to help relax those muscles again. And skinny stool, again, is with muscle tightness in the back. So shortened pelvic floor treatment is often some one-on-one work with me or somebody like me. Muscle release can be external, meaning undressed from the waist down. I put my hands on those muscles right by your sit bones, and I actually do a specific release to let go. I can teach people to do that on their own as well. Depending on where pain is, I may or may not do a rectal exam. The rectal exam for a physio is a bit different than with a physician because I'm actually looking at all of the muscles and I actually go backwards, forwards, and side to side. It's not as horrible, I've heard, as it sounds. But basically what we're trying to do is get really specific about which muscles are tight, and then I can actually go in there and release them. And then we see how it affects pain. If your pain goes away, and that's the cause of your pain, then I teach you how to do it yourself and work on stretches to manage it. If that doesn't work, then we can actually involve the physician and do specific injections. It's really quite astounding how much we can do in physio without actually getting to injections or needles. So that's a lot of what I see is trigger point releases externally and internally. The other thing that's really important with a shortened pelvic floor is actually noticing if you're pushing when you're in the bathroom. So if you are pushing or straining to empty your bladder or empty your bowel. When you push, if we look at this container again, when we push, we're actually doing this. So you're shortening the container and putting extra pressure downwards. Because your pelvic floor is dynamic tissue, it's like an elastic. If you push down on tissue that is elastic, it will tighten up to protect you. So not only are we dealing with a shortened muscle group, but anytime you're pushing down, it actually encourages that muscle group to tighten more. And so a lot of this managing shortened pelvic floor is actually learning how to function throughout your life without doing for one reason or another. So with exercise, we just tell people to exhale with effort, or if you're lifting something heavy, if you're shoveling snow, always exhale anytime you feel like you want to hold your breath. And the biggest thing is no Kegels. So again, that is one of the things that is often really confusing to people, because sometimes when you have pain or you have bladder leakage, especially if they happen together, the automatic thing to think of is, oh, you just have to do your Kegels. But leakage can still happen if you have a shortened pelvic floor. And the reason that happens is that if your muscles are really tight, it functions less like an adaptable surface, and it functions a little bit more like a trampoline. So it's like stiff like this, and then your bladder kind of bounces on it, and we can squish urine out in that way. Normally, when you're walking, your muscles kind of do this and then protect that leakage from happening. But if it's short, not only are you not emptying completely, but then bladder with some urine in it is bouncing on a harder surface. And so leakage can happen that way. So it's always nice to know if you need strengthening or if you need more relaxation. That is the key to deciding whether or not we need Kegels. Okay, so here are some beautiful pictures coming. So outside of this container, I stole this off the internet. So outside of this container, there are a couple of things that can contribute to pain in your pelvis. And like I said, those contributors can be as high as T12. So your spine goes cervical, thoracic, lumbar. Thoracic is your rib cage. And the very last vertebrae at the bottom of your rib cage is called your T12. And so right from T12 all the way down can be contributions into your pelvic floor. So after I've done all of that assessment, then I look at your hip flexor muscle. So basically, this muscle is the muscle that shortens when you sit down. It's the muscle that we use a lot of the time throughout our life with sit to stand, with skiing, with going up and down stairs, things like that. And it's a muscle that if I poke you in your belly, just a couple of inches away from your belly button, if I push straight down, that will get the middle of that muscle. So what I do is I kind of see throughout that muscle if there's tension, if there's trigger points, and if that muscle is actually lengthening all the way. When that muscle doesn't lengthen all the way, because it crosses so many joints, so you have the vertebrae, so the bones in your spine, it crosses the joints in your pelvis and crosses your hip muscle. So when that muscle is short, it can really affect how your body moves through the world. The reason that becomes important is not only because it's contributing to muscle imbalance, but also because of the nerves that follow along that muscle. So not only is it the muscle itself, but also certain nerves. I wrote down 2 of the big ones, but there's about 6 nerves that are important that go down that way. The ilioinguinal sends information down to like the front of your thigh and into your groin crease, and genitofemoral sends information right into your pelvic floor and right into your genitals. So that's often, I see a lot of people with testicular pain, and oftentimes we hone in right into that psoas muscle. And so once we release that muscle, stretch it out, it's less tension on that nerve, and then pain becomes managed that way. So the fun thing about figuring out pain, because the experience obviously is not fun, but it's trying to figure out the pieces that contribute to it, and then go right to the source in terms of nerves and see if we can fix that imbalance that way. One thing that's interesting is because we are dynamic beings and we move through the world, there are certain muscles that tend to tighten in patterns. And so a couple of muscles that are associated with pain in kind of in the pelvic pain world are hip flexor. So this muscle, pelvic floor, and your inner thigh. Those 3 areas tend to get tight together. And so it doesn't necessarily mean all the time, but if somebody has a tight hip flexor, so this particular muscle, I'll always give them stretches for those other muscles as well, because we can rarely pin things down to one dynamic structure, because we are dynamic beings that move through the world, and a lot of things have to work together. So this is also when we look at what are you doing for exercise? What are you doing for movement in your life? And how are those things actually impacted by your pain? And how can we make sure that they're not making pain worse? So this particular muscle, because it's so big and because it crosses so many joints, this is also associated with poor core stability. What that means is that sometimes when this muscle is really tight, we tend to lose the strength in your glutes, and we tend to lose the strength in your lower belly. It's not that it's automatic, it's just that when your psoas likes to work all the time, it tends to be the first one to work. So when I'm going to lift something, or I'm going to like pick myself up from sitting, we just have to look at, do we want your psoas to be the driving force, or do we want your bum to be the driving force, right? So it's kind of like the timing of the muscles that do certain activities that can actually contribute to your pain. Okay, so if there is specific nerve irritation, it can be from your lumbar spine, so from your back, a little bit higher from your rib cage. It could be, so those muscles that we talked about related to your psoas that go into your pelvic floor. There's 2 nerves right in the bottom of your pelvic floor that you may have heard. Pudendal nerve, people talk about a lot, and then obturator nerve. So those are the 2 nerves that are really low down that actually come from your sacral nerve roots, which is part of your pelvis. Those nerves are the ones that sometimes get compressed, especially pudendal. So if you're at a job where you're doing a lot of sitting, especially driving, like long distance driving or cycling, a lot of cyclists have issues with pudendal nerve. If we know that it's a specific nerve issue, then we look at how we can release pressure on that nerve So decompress, whether it's looking at your sitting surface or changing what you're doing or specific stretches. If that doesn't work, then we can actually do a specific treatment with a physician to actually do a nerve block or inject that area. With physio, what we tend to do is do soft tissue work around that nerve, so the nerve isn't being squished by muscles around, and then do stretching to accommodate that. If that doesn't work, then we go to looking at injections. Well, this is a little bit blurry, but what it says is the pain's mostly just in my knees. That's what that says. So I'm going to do a bit of a turnaround. So those are specific mechanical things that can contribute. So mechanical meaning when I have pain and I can do a movement or do a maneuver and have that pain go away, that means that it's definitely within what we call the mechanical or medical model of treatment. What happens when this pain becomes chronic, we look at pain in a different way. So what we used to call chronic pain or acute pain, it used to be really dependent on time. We would say 0 to 3 months pain we'll call acute, or within like 0 to 6 weeks, we'll call that acute pain. 3 months or more, we'll call that chronic pain. What has changed now in the pain world, especially in the last 15 to 20 years, is we've discovered something called central sensitization. So let me know if this is too much. I'm going to show you a quick little video that explains it in a more of a fun way than just me talking. But chronic pain, we now call persistent pain, or what we call central sensitization. And central refers to your central nervous system. So something is actually happening within your brain to change the way that your body is experiencing pain. So this is a very key switch in terms of our understanding of what's happening within somebody's body. So when you've had a pain that is persistent, it isn't changed by certain positions or certain stretches. We can modulate the pain, but it doesn't really go away. We actually have to look at your nervous system. So when we look at what pain is an alarm system that something is happening within your body, right? So if I'm walking and I stub my toe, sends a message to my brain that, oh, you just hurt yourself and you have to be careful because there is a stone in your way, right? So then I go, oh, I have to be careful that I'm walking and I don't hit another stone so I don't hit my foot again, okay? So you get that pain to bring your brain's attention to that area. If we think of your pain almost like a smoke alarm, right? So if I have a brand new smoke alarm and I'm happy if there's a fire in my house and the smoke alarm goes off. But if my 12-year-old, true story, if my 12-year-old is having a shower and the steam from the bath triggers the smoke alarm, that is a little bit too sensitive of an alarm system to actually do what I want it to do. So I'm glad that my alarm system went off, but it might be too big of an alarm for such a small thing because my house isn't burning down. Okay, so I am going to show you this. It's not very long. It's about 6 minutes. So this gives us a little bit of an introduction to how we are now thinking about persistent pain.
Once upon a time, all the lands were fraught with persistent pain. So widespread was this affliction that 1 in 4 people experienced it. The pain lasted for more than 3 months. It shadowed their daily lives, held them back from everyday activities, and the interventions they tried proved useless. Hey, pain, go away, we've tried it all, but still you stay. Moving less, taking pills, knives and needles, and still we're sore. We can't take no more, no more. But the pain remains like a loyal companion. The people's hopes faded, and they became resigned to living with the pain. Only now the pain was a beast. Then along came a group of researchers, of which I am one. Back off, big fella. I'm Professor Lorimer Mosley, and I'm a pain scientist. Pain scientists are starting to think differently about pain and its causes, and we're making exciting discoveries, like how the way you think about your pain can change the way it feels. Over the next few minutes, I'll help you to understand your pain. Understanding is important because it can change how much things hurt and how much your body can do. and it can help you to tame the beast. First, trust me about this. Pain is not an accurate measure of tissue health. Pain is a protector. By making unpleasant feelings, your brain changes your behaviour so you can avoid injury or your tissues can heal. Sometimes pain is not helpful, like phantom limb pain. You don't expect a missing limb to ache, but it does, and the pain is very real. So how do we explain this? Well, pain is a warning signal from your brain that depends on credible evidence to say your body needs protecting. Sometimes pain's too protective and you get unnecessary warning signals. Pain scientists now understand that there are many ways our nervous system ends up producing unnecessary warning signals. Take conditioning, for example. You think of Pavlov's dog. Every time food was offered, Pavlov rang a bell. Of course, the dog would salivate seeing the food. This went on for a while. Eventually, the dog was conditioned to salivate for the bell alone. Well, conditioning is just one of the ways your body learns pain. And the longer your nervous system produces pain, the better it gets at producing it. Your body learns pain. So what feeds this beast? Well, let's look at how pain works. In your body's tissues, there are specific neurons which normally only respond to harmful stimuli, whether mechanical, chemical, or thermal. When they are activated, they send a warning signal to your spinal cord, which can in turn send a signal to your brain. This activity in neurons is called nociception, and it's happening all the time, but only sometimes results in pain. Most of the time, the brain protects you with other things, like movement. Once the warning signal reaches the brain makes sense of it based on the information arriving and a vast amount of information already stored. If there's good reason to think protection is required, then your brain makes pain. One of our amazing discoveries is that you can have pain without any physical stimuli. Thoughts and places might activate the warning signals, and the pain feels exactly the same. But it's not just your brain. Your spinal cord also learns how to generate unnecessary warning signals. So how do you know when your nervous system is learning pain? You may notice your pain spreads or comes on without warning. Your body feels odd and it's hard to move properly. Your pain changes quickly with your mood and small annoyances can set it off. Old injuries start to hurt again. You're more sensitive to stimuli. And the longer the pain goes on, the more all of this occurs. The old way we understood pain could not explain these things and left many sufferers feeling like no one believed it was real. Or for it to hurt so badly, there must be a major tissue problem. But we now know how persistent pain happens. So how can you tame the beast? Pain is a very personal thing. There's no one-size-fits-all solution. And while you probably have well thought out coping strategies, it's time to take a new approach to dealing with and reducing your pain, one that focuses on retraining your pain system. This might mean testing yourself physically and moving more than you normally would. Being honest about your current attitudes and beliefs can also help, as can asking your health professional new questions.
How do I know if my pain system is being overprotective?
How do I retrain my pain system to be less protective?
How do I know if I'm safe to move?
So be brave and have hope, because it is possible to tame the beast. Visit our website for more information and questions to ask your health professional. tamethebeast.org.
I love that little video. It's got so much information in it that sometimes it actually takes going back and watching it again a few times. But it is a very different approach, and it's what we call the biopsychosocial approach. And so the traditional medical model looks at kind of all the things that we talked about so far. If there is any specific physiological something happening which requires medication, or is it something mechanical that we can actually break apart, come back to the source and just alter things in that way? Or is it because the whole system is actually sensitized? When the whole system becomes sensitized, we approach things in a completely different way. We actually look at if we can turn down the sensitivity or turn down the volume of that whole pain system. And so the approach becomes very different. And so there's this word that on the bottom of this, it's neuroception, it's a new word. It's developed by Dr. Stephen Porges, who came up with something called the polyvagal theory. We don't have to go into that now. But basically what he talks about is that your brain is constantly, like every millisecond, is constantly scanning for safety or danger in an environment, whether it's physical, whether it's social cues, whether it's environmental. There's all of this information coming into our brains all the time, and we're constantly scanning for safety or danger. And it's when your brain perceives danger that it triggers and contributes to that pain system. And so treating a sensitized system for pain actually looks at a lot of different things. So it looks at body awareness, it looks at communication, it looks at developing what we call pain coping skills that are taught by all the professionals at the pain center. But later on, I put a website where you can actually look at what those are. It's through the Chronic Pain Center. The big things with persistent pain is knowing that everyone's pain experience is different and all pain is real. Big capital letters, all pain is real. The pain experience is impacted by a lot of different things, some of which are your mood, social environment, stress levels, especially quality of sleep, your activity level and what you do for movement. And one thing that I always ask people is access to moments of joy. And although that sounds like a very simple thing, when we think about when your body is in danger and you're in the woods running away from a bear, so running for your life, in that moment, you're in that fight or flight space when your brain perceives danger and then you know you're in a dangerous situation. It is difficult in that moment for you to actually experience joy because that's not a priority at that point. And so when somebody is experiencing persistent pain, I ask people to put little snippets of joy within their day. In that way, we're actually pressing pause on the threat or danger system. It's such a simple thing, but any way that we can actually press pause on the system, whether it's meditation, relaxation, breath work, or joy, that will help us to manage and see where we can go with managing pain. So these are just a couple of resources that I really like. So Tame the Beast, the video that we just watched is from that website. And Lorimer Moseley also has a number of TED Talks that you can find on YouTube where he goes into, he's a great storyteller. He makes neurophysiology pretty fun. Pain Society of Alberta. It's a pretty vast website, but there's a button that says I live in pain or I live with pain. And if you click on that, that will take you to appropriate sections of the website. And the Chronic Pain Center developed the 5 big skills for managing pain. And then there's a lecture series that breaks down all of those pain coping skills. And that's at this link. And it's on the AHS website. So that is the bulk of what I wanted to talk about. Does anyone present have any question or comments?
Wow, lots.
That was a lot.
It was, but so excellent. And again, I always learn something. And while your topic was on pelvic pain, it really could be applied in many different situations. And the one question I had was when you look at the pelvic floor,
Yep.
and some of us have had radiation there, how would that impact pain down the road? Is there signs that we should be watching for, or?
That's a really good question. So with radiation, what happens is the tissue actually changes, right? Like the tissue is a little bit less flexible and there's less of a dynamic nature to it. So the same kind of thing. So I would look for so pressure, discomfort, and also if you can feel the difference between contraction and relaxation with different things. So if I contract the pelvic floor and I relax, make sure that you can feel the difference in that and make sure that it's not affecting urination. But it does become tricky if that those particular muscles around that area become a cause of pain, we can do some release of those muscles, but it does reach a limit.
Yeah.
And the other thing that we can do is we can do some soft tissue work around that area to minimize the impact.
Yeah. Now we had Warren up in Edmonton has raised his hand. Go ahead, Warren.
Yeah, do you recommend using supplements like Metamucil or probiotics for any benefits in any way with bowel pain?
That's interesting. So the short answer is yes. Make sure you're talking to your physician or a dietitian, because it sort of depends on what's happening with your bowels. So our goal in terms of how we want your bowels to function in terms of pain is we want to make sure that we're not leaning towards constipation, right? So make sure that there's no cramping within your bowels, and that you can have a bowel movement without straining, pain, or increasing the pain. Yeah. So if you are taking Metamucil to manage constipation, then yes, definitely. I would say probiotics, I would just discuss with your doctor in terms of what else you're on and which probiotic is appropriate and all of that stuff. So the big caveat with fiber and Metamucil is if you are somebody who has a tendency towards larger stool, we might have to play with different types of fiber. That's the only caveat. So that's why it's nice to kind of talk to your practitioners that know you a bit better. Is that fair? Okay.
Now, many of us have, we'll have a urologist, we'll have a medical oncologist, we'll have a family doctor. Is there one best way to connect with services of a pelvic or health physiotherapist such as yourself?
That is a really good question. So one thing to know about pelvic health is pelvic health is a specialization within physio, and then treating men is another specialization. So there's about 8 to 10 of us in Calgary. So we all know each other. So in terms of finding a practitioner, honestly, it tends to be through urologists because they know us. But you can always also ask your family physician. It really depends on who knows kind of who's out there and appropriateness of physio. But the Prostate Cancer Center or urologists tend to know a little bit more about appropriateness. That said, you can always just walk in and book with a physio. You don't need a referral.
Yeah. That was where I was headed next. Is if I'm experiencing some pain in the pelvic area, and I need to know where best to go, and I've talked to, say, my family doctor, and they're.
I would check with urologist. Like if you have access to your urologist pretty quickly, I would check with them, just because you're already hooked up with them.
Yeah, some of our members, of course, are under active treatment, so they'll be seeing their urologist on a regular basis, and I would hope that that's the type of conversation that they would be discussing as appropriate. Yeah.
Yes, absolutely.
Frank is in Calgary here, so Frank, go ahead.
Yes, thank you, and thank you for the presentation. I was wondering if you could comment on if you've got some metastatic disease and it's in your pelvic bone area, but on a rather limited or minor scale. What would be the difference between, let's say, bone pain and then muscle pain in that area? How would you distinguish the two?
That's a very good question. So bone pain tends to be a really deep kind of ache. Muscle pain in particular can change. So if I have muscle pain and then I take a hot bath or I do movement stretch and it goes away, then that is likely more muscle than bone. Bone pain tends to be persistent, and especially if it's waking you up at night.
Yes, thank you very much for answering that.
But it's good to know the difference, especially because it can be concerning, right? And you want to make sure that if you have control over it, then it's more likely to be soft tissue. But always, of course, keep in touch with your practitioner so they can keep an eye on.
Now, this may not be a direct question that you could answer, but one of the things that I often get asked is, here, what's the difference between prostatitis and BPH? The similar situation for men, so it's often confused as to which is which.
Yeah, and it might be better for a urologist to answer that, but I can tell you my understanding. So in terms of the term, so benign prostatic hyperplasia just means that there's an enlargement, whereas prostatitis is an inflammation of the prostate. And
Yeah.
so when we think about BPH, we're thinking about the mechanical effect that it has on the area, right? So like kind of squishing on urethra. When I think about prostatitis, we're actually thinking about inflammation and something that's requiring medication.
Yeah. Yeah, and it's not really any way for anybody to tell without the service of a urologist is
Or
really.
doing a trial of medication.
Yeah, exactly. Good. Wow, you're getting off easy, Safa. Oh, no really hard questions for you, but that was an excellent presentation. I've been getting some notes sent to me in the chat here that everybody was thinking or commenting on how good the presentation was, and we had an opportunity tonight to have a look at something. On the final note, then I'll just say, is there any way, or are you looking at introducing this type of topic pre-surgery? Because I think it would be.
I would love that.
I know.
I would love to have access to people pre-surgery. I've had a few people come to physio pre-radical prostatectomy, and it just kind of prepares you a little bit, just in terms of what pain is concerning, what pain is treatable, and also to actually start with some pelvic floor exercises. So if I could see people pre-surgery, I think that would be great, because it just starts you off a little bit more educated.
I mean, I'd never even heard of Kegel till I got handed the pamphlet on my way out of the hospital after surgery. And I just think, wow, if I'd had some information beforehand.
I agree. I think that's something that I think we should work on.
Yeah, I agree. Thank you so much. We appreciate you sharing your information with us tonight. I know how valuable time is, and we do so appreciate you making time for us this evening. Thank you.
Thank you so much. I'm always so delighted to talk about pain, because I don't think it's talked about quite enough.